He went to undergrad at Brown University, where he stayed and got his degree, or he got his degree in biomedical ethics. It's going to serve him well later on in his life. He stayed at Brown for medical school, then did his residency and a year as a chief resident at Beth Israel Deaconess in Boston. After that, he's done many things, including doing his Robkin Fellowship in medical education, which is when Tony and I met and became friends. Tony teaches at Harvard Medical School. He is a hospitalist at the VA in Boston, where he's the medical director, and he teaches in the Harvard Medical School Center for Bioethics, where he's the course director for the Essentials of the Profession course. Tony may be very well known to a lot of you for his tweetorials that he posts on Twitter. He's kind of like the father, the godfather and the father of the tweetorial. For those of you who haven't seen these, they're really incredible historical analyses of common questions that we often ponder in medicine, such as how does calcium stabilize the cardiac membrane in hyperkalemia? Why is too much oxygen harmful? Why is ferritin elevated in anemia of chronic inflammation? And why do patients with primary polydipsia keep drinking? Today, Tony's going to talk to us about another one of his academic passions, for which he serves as an associate editor for Things We Do for No Reason. It's a series in the Journal of Hospital Medicine. And before I continue to introduce him, I also want to comment that as great as Tony is as a physician, an educator, and a mind, he's also a great friend, a great person to go out with for happy hour, and also a wonderful father and husband. So thanks, Tony. Take it away.
So David, you said we're recording that. I can take that recording where you just said nice things about me and
send it to your mom.
All right, done. All right. So grand rounds is over. Perfect. All right, but actually was really a very gracious introduction. I appreciate that, David. And it's too bad that we haven't been able to see each other face to face, but it's nice to be with you guys remotely. Before I introduce the topic, I want to take another 10 seconds for people to figure out how to use the annotate function, because we're going to use it a few times over the course of this discussion. So you'll notice that if you're on a desktop, if you hover towards the top of the screen, there should either be an annotate button or a drop down, and then you can either stamp or draw in one of these 4 boxes. And then if you're on an iPad or a phone, there should be a function at the bottom left that should allow you to do the same. And I can see here that we've got a pretty wide-ranging audience, including some folks who are agnostic and have indicated they are none of the above by going across the top of the screen. So I'm going to clear these because I want to move forward, and there may be some annotations that come on, and I'll try to clear this a couple times. And before I tell you exactly what I'm talking about, I want to present you with a case. And so this is a patient, Mr. Fish, presenting with a chief complaint of heart failure. He's a 60-year-old man, and this is an acute presentation of chronic systolic heart failure. And his labs include a creatinine of 1.1, which is the baseline, a sodium of 136, and a BNP of 921. And I have 2 questions that I want you to ponder and answer in just a moment. One is, in addition to goal-directed therapies, would you recommend that this patient be placed on a sodium-restricted diet? And 2, what would be your first choice diuretic? More specifically, first choice loop diuretic. So we're going to start with this question. And again, you're going to annotate either yes or no as to whether or not you would place this patient with acute heart failure on a sodium-restricted diet. So I'll pause for a moment. Most of you, or many of you, have learned how to annotate, so I'll have you take a moment to do that. Okay. So we've got maybe 60-40. Certainly, there is some enthusiasm in the audience for sodium restriction. I'm going to clear here and move on to question number 2, which is, what would be your first choice loop diuretic for this patient? Would it be furosemide, torsemide, or would you choose another loop diuretic that I haven't listed here? All right, so we have one very aggressive X in favor of torsemide, but the remainder of the audience is more enthusiastic with furosemide. Okay, So as you may have guessed, based on David's introduction, as the deputy editor for the Things We Do for No Reason series and someone who's done some research in the topic, I'm going to argue two things today along these lines. The first is going to be that we place patients on sodium restriction who have acute heart failure, and that is the thing we do for no reason. And I'm going to argue that we use too much furosemide and we should instead be using torsemide in the treatment of heart failure. And as we go, I really have two main audiences anytime I make these arguments. The first are the non-believers, those of you who continue to sodium restrict and continue to use furosemide. And what I'm hoping to do is offer you some arguments to maybe consider coming around to my way of thinking. And then there are certainly people who are already in the audience who don't sodium restrict and who like torsemide. And what I want to do for you is arm you with additional arguments so that you can help to change the culture around you if you think that's important, if you think that we ought to be doing that. So let's start with this first topic of sodium restriction. And it must make some sense for us to do this, or else so many of us wouldn't do it. So what makes sense about it? Well, sodium intake is a modifiable risk factor for hypertension. And in randomized trials of low sodium diet, blood pressures will be lower. And I think, as we know, hypertension is a predisposing condition for heart failure. I learned in elementary school that water follows salt. And I think we all know that congestion is a major feature of acute heart failure. So, if there's a lot of sodium around, the worry is there's going to be a lot of water around and one is going to become congested. And there is some observational data suggesting that sodium intake is associated with acute heart failure, but this is observational data and the hazard ratio is only on the order of 1.2 to 1.4. So if you know me, you know I like to talk about pathophysiology, so I think we're going to have to talk about that for a moment. And I'm going to offer you my rudimentary understanding of the pathophysiology of acute heart failure from the time I was intern through a few years ago. And it really began with acute increase in sodium intake. As an intern, I would go to see a patient admitted with acute heart failure, and if they told me they ate Chinese food sometime in the last few weeks, like that was my history of prison illness, right? Patient ate Chinese food 2 weeks ago, now presenting with acute heart failure. Because the way I envision it, you eat a lot of sodium, you now retain that sodium in water, you're in heart failure. I'm a great doctor, because all I got to do now is reverse that process, restrict their sodium and water intake, give them a few diuretics, do this for a few days, and there it is. I'm great. I'm a good doctor. And the reality, of course, is this is an oversimplification. And I'm going to come back to this slide in a few minutes to show you why. Well, do we do it? Do we actually sodium restrict? I think the argument or the answers you provided a few slides ago suggest that we probably do sodium restrict, though maybe not as much as we did a few years ago. And what's interesting is that the Heart Failure Society of America, ACC, AHA, and the European Society of Cardiology are somewhat inconsistent. Two don't even comment. And then the oldest one, that's 21 years old, they do recommend a less than 2 grams sodium restricted diet. And this is for acute heart failure. This is not their comment on chronic heart failure treatment. This is just in the setting of acute heart failure. So I'm going to make 3 arguments. First, I'm going to suggest to you that the evidence shows there is no benefit for sodium restriction, and that there may actually even be harm, and that the harm and the lack of benefit has a solid pathophysiologic basis. So let's start with the evidence. And I must grant up front that the studies I will share are small. They are usually single center, so they have problems. But I'm not withholding like the enormous study of sodium restriction that showed benefit. Like this is the data we have. So this study, I think many of you have seen before. It was published in June of 2013 in JAMA IM, a single center study, and it was an RCT, and it included patients with acute systolic heart failure with reduced EF. And what they did is within 36 hours of admission, they randomized to either a restricted arm or a liberal arm. The restricted arm was very restricted. So 800 mLs of fluid and less than 800 milligrams of sodium. So they did not mess around when they said, we're going to restrict you. And in the liberal group, they had goals, but they didn't monitor or restrict if someone went over 5 grams or went over 2.5 liters. To give you a sense for how restricted this is, it's about 250 mLs of normal saline. So for the residents in the room, if you give a gram of vancomycin, it is typically mixed in 250 cc's of saline. So you've given them their sodium for the day if they're in this trial. And then 800 mLs of water is about the size of a venti iced coffee at Starbucks. So we're really not talking like about a lot of intake here. There were 2 co-primary endpoints. The first was change in weight, and they looked specifically at 3 days. But you can see here, there's also the end of the study as well. And there was no difference in their change in weight. And so I've placed that in red here to indicate no difference. They each lost about 9 to 10 pounds or about 4.5 to 5 kilograms of water. So they did pretty well. They did, in fact, have a pretty good diuresis. The other endpoint was the clinical congestion score. And this is a 7-item score, includes physical exam and history. And you can get a maximum of 22 points for this score. And what you again see is there's no difference in the change in the score between the 2 groups. Both groups improved the amount of congestion they had. In fact, the only thing they saw that was different was the amount of thirst that they experienced. Once you got out to 7 days, the patients who were in the restricted arm were more thirsty. Now, I don't think any of us are surprised by that, but I do want you to ask yourself this question: what drives thirst? And I'll tell you, there's 2 main drivers of thirst. One of them is an increase in osmolarity. These patients did not have an increase in their serum sodium, so I doubt they had an increase in osmolarity. But there's another molecule that increases thirst, and I want you to think for yourself what that molecule might be, because I think it plays a major role in what's going on here. In this study, they followed the patients out to 30 days, and their weights were no different. Their clinical congestion scores were different, though. The patients who were restricted were more congested at 30 days. And in fact, their congestion had increased while the congestion in the patients who were allowed to eat and drink liberally had decreased. Readmissions were no different, though numerically there were a few fewer in the liberal arm. But they were so few that they really obviously weren't going to see statistical significance here. All right, so that's study number 1. Study number 2 was published 3 years ago, also a study from Brazil using the same level of restriction. I've highlighted the author because this author was the senior author for the first study. And the major difference here was that these patients had preserved EF, where the first study, the patients had reduced EF. And they found very similar results. No difference in weight loss or change in clinical congestion. No difference in the number of days from transition to IV to oral diuretics. So the clinical outcomes were no different. But again, the patients were thirstier in the restriction arm, which, maybe that's a quaint outcome. Oh, how nice of us that we're asking about thirst. But the reality is, I think this outcome is of extreme importance. Again, I'm going to hold on that point for a few more slides, though. So final study for evidence is this study which increased the amount of sodium a bit. So the first was 800 versus liberal. Here they went 3 grams a day versus 7 grams a day. You can imagine, oh my gosh, 7 grams, that's way too much. These patients are going to do worse. The reality is the weight loss was no different. The BNP was decreased more in the 7 grams group. I don't know if that really has any clinical relevance, but the length of stay was 7 days shorter in those who were allowed to eat up to 7 grams a day. That is interesting to me. So let me summarize these 3 evidence studies. One is that when patients are placed on sodium or water restriction, There was no difference in the change in weight or clinical congestion or time to clinical stability. But we did see this signal for increased thirst in those first two studies. I don't know what to make of that improvement in length of stay if you were allowed to eat more salt. It's just one study, so I don't want to make too much of it. But it certainly wasn't the reverse, right? It wasn't as though the restricted arm was being discharged 7 days earlier. Okay, so maybe sodium restriction isn't beneficial, but I said earlier that it might be harmful. And so if it's harmful, I got to explain to you why that is. So here again is my understanding for 11, 12 years of the pathophysiology of acute heart failure. Here's my understanding as of now, and I will tell you what I'm going to show you is going to still be oversimplified. And the reality is, I think our understanding of the pathophysiology of acute heart failure remains somewhat rudimentary. We still have it here at the bottom, but across the top are more things than just increased sodium intake. I've listed 6 of them here, and the reality is that there's probably something even higher than these six items that need to feed into these, but we've got to start somewhere. And I'm just trying to show you the complexity of acute heart failure. These lead to not only sodium and water restriction, but also just shifts in water. Many patients who have acute heart failure don't have a dramatic increase in their total body water or their weight. They instead have shifted the place that water is appearing, and that's the problem. And then these patients often have a vasoconstriction. And these lead to things like congestion and organ dysfunction and the syndrome of acute heart failure. So if we come back to the way I had handled things for a number of years, and I restrict a patient, the fear is that is going to activate the neurohormonal axis. And I'll show you evidence for this in a moment. And if it turns out that the high level problem is the neurohormonal axis, don't I want to do whatever I can to not activate it, because that's actually the problem, right? So that's the argument I'm going to make. So does sodium restriction increase the neurohormonal axis? Absolutely, yes. So this is a meta-analysis published last year, includes dozens of studies, and it shows increases. You can see the number of studies and the number of participants. All or consistently, you see an increase in renin, aldol, norepinephrine in these studies. Now, what I'm showing you here are populations that don't have heart failure. So I'm going to have to show you heart failure populations in a moment. But this is just to give you a sense that, in general, if you sodium restrict someone, their neurohormonal axis is going to be activated. To give you a sense for the consistency of this finding, this is an older version of the meta-analysis, and here is the line of no difference. They're all to the right, right? This is not like one of those where, oh, the summary statistic suggests it, but there's a little bit of left and right. They're all to the right, showing that there's an increase in renin and aldol. I'm not showing the norepi and epi here. All right, and what about patients with heart failure? So here is a study looking at 1.6 grams a day, and they looked at norepi, epi, and angiotensin 2, and they compared that to 5.7 grams a day. And you'll notice that the norepi and the angiotensin 2, I placed those in green because those were statistically significantly decreased in the patients who were not restricted. To put it another way, if you were restricted, you had more of an increase in norepi and angiotensin 2. They didn't find a statistically significant difference in epinephrine, though numerically, again, the number is higher in the restricted arm. So that brings me back to this figure from the first study I showed you. And what I see here is that I'm restricting one set of patients, and I'm increasing angiotensin 2. And angiotensin 2 is what makes us thirsty. So a lot of people think it's ADH, it's actually angiotensin 2. And if angiotensin 2 increases, that suggests that RAS is activated. So what I see here is that patients are restricted, their renin-angiotensin system is activated, On day 7, they're more thirsty because of that. And then what do? We discharge them with a more activated neurohormonal axis. And then we are surprised when they're readmitted at within 30 days for additional heart failure. That's the argument that I'm making. And others have pushed this such that they give salt for acute heart failure. So here's one example, a randomized trial of 44 patients with acute decompensated heart failure. We're going to supplement you with salt. In this case, they gave 1.7% saline, so hypertonic saline, versus just glucose. And in the hypertonic saline group, again, they got 1.7% sodium chloride. This is about 8.5 grams of salt. They both got furosemide, and then they got even more salt. And they both got up to 6 grams a day. And they were put on a pretty strict fluid restriction, which I find very interesting, but maybe this is more palatable if you're not as thirsty because the neurohormonal axis isn't as revved up. And so you notice the real difference here is that one group got hypertonic saline and one group got D5W. And this is 20 cc's an hour, so it's 500 mLs. It's not a lot of fluid. So collectively, between the 500 cc's of fluid, either hypertonic saline or D5W, plus 500 that you're allowed to ingest, they could take up to 1 liter a day of fluid. The urine volume was higher at 24 hours in the hypertonic saline group, and the GFR was higher in the hypertonic saline group. Numerically, there was more weight loss, though you can see the p-value didn't meet statistical significance, and the pro-BNP dropped while in the non-hypertonic saline, it increased. Again, I don't know the clinical relevance of that, but it's interesting. And so this has been studied by many others. There's an Italian group who's done this extensively. And so I'm going to show you the meta-analysis of the use of hypertonic saline, just to show you this isn't just one group. So this was 4 observational studies and 10 RCTs, nearly 3,400 patients. There's going to be a lot of green here. There is more improvement in creatinine, more urine output, and more weight loss if you give hypertonic saline, a decreased length of stay, decreased readmissions, decreased long-term mortality. This is like a lot of green. In yellow is in hospital mortality. It's not red because it's not harmful, but you can see here that the risk ratio is actually above 1. So it's worth noting, but it certainly didn't meet statistical significance, and the confidence interval is quite wide. And the long-term mortality, it was a clear benefit. All right, so sodium restriction doesn't lead to better outcomes, at least based on the small randomized trials we have. I've tried to argue that it may lead to worsened pathophysiology with a resulting worsening in outcomes. So I have 3 recommendations. The first is if you care for patients with acute decompensated heart failure, I would argue not to place them on a sodium restricted diet. Many of you, if you're hospitalists, certainly the residents in the room, you certainly take care of heart failure patients. You don't want to do this in isolation. You want to talk to your colleagues around you. I'm making an argument, but it's important to verify what I've shown you before you sort of take the leap. Although some of you maybe have already taken the leap. Now I'll tell you what I've said here doesn't apply to compensated heart failure. I think there is a shift in our feeling about salt intake in even compensated heart failure. But I think there's been less of a push away from sodium restriction in that population. So what I'm really concentrating on is the acute heart failure setting, which as a hospitalist is what I care for. And I think if you find this convincing, it's going to be impossible for you to change practice in isolation. Things like order sets are really what matters. And so if you think any of this is convincing, ally with your local cardiologists, look at things like order sets and see if you can try to change practice at a more institutional level than you as an individual, because I don't think anything is going to change if we as individuals just say, I'll no longer restrict, but every other resident in the program, every other hospitalist, every other cardiologist continues to do so. All right, so have I convinced you? So you're going to annotate here. If you are much more likely, much less likely to restrict, you're going to annotate over here. If you're much more likely, you're going to annotate over here on the left, and I'm going to just end the session because that means I'm really doing a horrible job. If you were or weren't restricting before, you've got your own little box here, and this is meant to be a gradation. You know how strongly you think my argument was. And while you're doing that, David, any questions that I should answer before I move on to topic 2?
Yeah, there was one question, you touched on this in your last slide about the evidence for or against salt restriction in outpatients. So you mentioned the compensated patients, but I'm wondering if you can just maybe take 30 seconds to delve into that if you have the evidence.
Yeah, so I haven't reviewed that literature as in depth, but I will say I think there's a bit more evidence supporting sodium restriction in chronic heart failure. But I don't think it is overwhelming, I must say. And I think we also know that it is hard to adhere to that. And so I think if I have a bias between trying to get my patient to take goal-directed therapy versus getting them to use a sodium-restricted diet, I'll probably favor encouraging them to use goal-directed therapy. I don't know if that may not be a satisfactory answer.
That's great.
What's interesting, I will say, is angiotensin 2 inhibitors. I mentioned that angiotensin 2 inhibitors, ACE inhibitors, they decrease thirst, right? So if angiotensin 2 is what leads to thirst, it should be of no surprise that ACE inhibitors can help to blunt thirst. They're not great at it, but they can do it. What else, David?
There's a comment. So you mentioned in the beginning about, well, I ate Chinese food 2 weeks ago, and therefore that's, punishing the patient. It's your fault. That's why you're in the hospital for decompensated heart failure. And while, I think we do blame our patients too much for many things, including heart failure exacerbations, there are patients who come in with decompensated heart failure because the night before they went to the movie theater and they had 2 buckets of popcorn, and maybe salt intake is the cause. So in those patients, would you change your perspective?
So it's interesting. There are observational studies suggesting that recent salt intake is not associated with acute heart failure. So I think we have a tendency to over blame recent salt intake. Probably one of the more important issues is medication non-adherence. That I think has been shown to be correlated with acute heart failure. But I think it's compelling and alluring to say there was a recent salt intake that must be the cause. I am not sure there's data supporting that, even though it is intuitively quite pleasing. So, okay, so this is good. I would love to talk to the 3 folks on the left, the 2 hearts and the arrow, to know what was it that made you so unconvinced? And that's actually in some ways like an honest statement. If you truly are more likely to sodium restrict based on what I've said, what I might be interested in is I'll put my email at the end. Send me an email, because I got to make my argument stronger, and I got to know what is not convincing. So
we're all cardiology fellows. We put that there.
Oh, you cardiology fellows, you. Do you want to offer some rebuttals?
No, it's my personal experience. Someone comes in with huge volume overload.
Yep.
Give them a diuretic. You have kaliresis, you have natriuresis, and wherever salt goes, water goes. It's worked for ages, so it's hard to wrap my head around not salt restricting someone in acute heart failure. So.
I agree, right? Habits die hard.
Yeah.
And just as you said, our experience suggests that it works. But that experience hasn't been tested. And so for something that I think is not patient-centered, is probably somewhat nursing intensive, and may make patients worse, I think we ought to question that experience occasionally. We cannot question all of our practices or else we'll grind to a halt. But occasionally we should question our practices. So on that note, let's talk about furosemide, because talk about something we're all quite comfortable with. I want to now argue, cardiology fellows, that we should be using torsemide. So I'm going to be very interested in your thoughts as we near the end of this session. All right, so why does it make sense to use furosemide in heart failure? Well, first of all, it's been around since the 60s. Torsemide was only introduced in the early 90s. So we just have experience with it, and we use it a lot. I'll show you data from this study I'm citing here in the next slide. And the ACC/AHA doesn't pick a side. They just say, here are some loop diuretics. You can use bumetanide, furosemide, torsemide. They don't really suggest ethacrylic acid, but they don't really say one is superior to other. So I think our clinical experience with furosemide has led to a continued experience with furosemide. And do we use furosemide? Undoubtedly we do. The study of 250,000 patients showed that furosemide was by far the most commonly used diuretic at discharge, with torsemide constituting less than 1%. And this data is now 8 years old, so it may be that more contemporary data this will have shifted this a bit, but my clinical experience still suggests that far and away the most commonly used loop diuretic in heart failure is furosemide. So I'm going to make 3 arguments. One is, again, evidence-based. I think there's evidence favoring torsemide. I'm going to make the same kind of caveats I made with the first discussion, which is that the trials I'm going to show you are not overwhelming. So I'm going to have to back that up with something else, and that's going to be the better pharmacokinetic and dynamics of torsemide, and the fact that torsemide is this kind of cool drug. It does more than just be a loop diuretic. So this is the first trial, and you'll notice that all of these are open label, and it is what it is, and I apologize for that, but this is the data we have. This is from the American Journal of Medicine, nearly 20 years old, an RCT of about 200 patients with heart failure, and they were administered either torsemide or furosemide for a year. And they looked at whether or not patients were readmitted. And there were fewer readmissions in the torsemide arm, let me rephrase this. There were fewer patients who had at least one readmission. That's the way you see that here. For heart failure, and then more generally for cardiovascular causes. There was curiously no difference in the all-cause readmissions. And then for total readmissions, you can see numerically heart failure, cardiovascular causes were lower. And for all causes, they were lower, but again, that p-value suggests it wasn't statistically significant. And you may rebut, well, maybe all these readmissions didn't occur with torsemide because the patients had an increased mortality. So let me show you the mortality data. Numerically lower in torsemide, did not meet statistical significance, but it wasn't as though the torsemide group was dying more, and that's why they were not being readmitted. This study also looked at fatigue and asked the question, how tired have you felt over the last 2 weeks? And they used a 7-point scale. And at baseline, you can see there was no difference. But at 2, 8, and 12 months, the patients in the torsemide group had more of an improvement in their fatigue. Whereas the furosemide group, once we got to 12 months, they were basically just as fatigued as they had been at the time of enrollment. All right, so that's the first study. All right, so it suggests that maybe we get decreased readmissions and maybe patients are less tired. Here's the second study, very similar, randomized but open label, about 200 patients, also nearly 20 years old. These patients had New York Heart Association class 2 to 4 heart failure. And what they looked at here was a change in the New York Heart Association class. And as you can imagine, they were particularly interested in those who improved by at least 1 score. So went from like 4 to 3, or 3 to 2, or 4 to 2, you get the idea. And they provided a p-value for improvement. And though 30% of the patients in the furosemide arm improved by at least 1 class, this did not meet their pre-specified p-value for improvement. but it did for torsemide. You can see 40% of the torsemide group had shown an improvement. So that's a 9% difference between furosemide and torsemide. And similar to the first study, they looked at some quality of life measures. And they asked the question, did you feel restricted by the diuretics in your daily life? And the torsemide arm had less restrictions in their daily life. And they didn't comment on whether or not this was related to fatigue or the number of urinations events, but nonetheless, there was less fatigue, less interruptions in their daily life or restrictions in their daily life with torsemide. So there's some of these hard outcomes like readmissions and potentially New York Heart Association class, because that's symptom-based. And then some of these other outcomes like fatigue and restrictions in daily life. All right, so here's the third study I'll offer you, and this is also open label. This wasn't randomized, but it was a post-marketing surveillance study. And I'm offering it because it's slightly larger, up to 1,400 patients. And actually, I'll tell you, this study included not just furosemide and torsemide, but other loop diuretics. And you'll notice I'm going to compare torsemide to furosemide plus the others. And they noted a mortality benefit, both total and cardiac, and more of an improvement in New York Heart Association class, less potassium derangements. And this last one is very interesting. So in the torsemide group, only 3% of patients required potassium supplementation, whereas nearly 30% required potassium supplementation in the other arms. And there was some discussion as to whether or not a decrease in hypokalemia maybe could be a driver of this perceived mortality difference, though this was not a randomized study. And we're going to come back to this because it relates to torsemide's non-loop diuretic effect, right? Because if they're all loop diuretics, shouldn't they equally lead to caloresis? And this study suggests that that's not the case. So I'm not going to offer you a singular meta-analysis. There have been a number of them done, but I will tell you that they consistently, meaning all the meta-analyses I looked at, they consistently show that the studies in aggregate demonstrate an improvement in New York Heart Association class. Some meta-analyses show an improvement in readmissions, meaning a reduction, and an improvement in mortality, but it's not as consistent. No meta-analysis that I've reviewed shows furosemide to be superior in any metric. So either torsemide is better or it's equal when you meta-analyze the data. All right, so why might it outperform furosemide? I mean, you may not have found any of what I just talked about convincing in terms of the clinical differences, but if you think any of that is convincing, let me offer you some explanations for why that might be. So first, torsemide has better pharmacokinetics and pharmacodynamics. And by better, I'll show you what I mean in a moment. I've alluded to this already, but torsemide might actually have RAS effects. It might be kind of like a spironolactone in addition to it being a loop diuretic. And it may even have antifibrotic effects. So let's start with the first point here. So I'm going to put in green anything that favors that diuretic, and then occasionally you'll see a red. So we all know that furosemide has, for some patients, poor bioavailability. That's one of the reasons why when someone's admitted with acute heart failure, we put them on IV, because we're like, oh, gut edema, maybe they're not absorbing. That's less of a concern with torsemide and bumetanide, which have more consistent bioavailability. And this is probably partly a product of the fact that torsemide is not affected by food, whereas the absorption of furosemide is. So if you have a patient who takes their medications with meals, like they take their furosemide with breakfast and maybe they take their furosemide with dinner, that may be interfering with the absorption of that drug. And that, of course, is problematic. I would argue that having a lower renal elimination is better because it allows for more consistent diuresis as GFR changes. And you can see that furosemide is 50% renally cleared, whereas torsemide is only 20% renally cleared. The onset of action for an oral dose is 30 to 60, 30 to 60, and then bumetanide, at least what I saw, everyone said it was 30, so maybe that's a little faster oral. They all have a similar onset of action IV within 5 to 10 minutes. So I don't know that one of these really wins the onset of action. I've highlighted bumetanide just to give them a bone. The half-life is longer and the duration of action is longer for torsemide, and I think that is better because it leads to a smoother diuresis potentially. And maybe this relates to this idea of like interference with life. And maybe, or actually does mean that you can dose torsemide once a day, whereas furosemide is typically a twice daily medication. The oral to IV conversion, I mean, this is just for those of us who are frustrated when we're like closing our eyes and we're like, oh my God, so we're converting from IV to PO and the potency is this, it's just a little bit simpler with torsemide, but I don't think that should be the controlling difference. So when you add it up, there's a lot of green for torsemide here, and there's nothing for furosemide where there's benefit. So where does torsemide win? Well, like I said, we're familiar with it. We know how to dose it. We've used it. We know it works. And if you're concerned about cost, this is some good RX data from hopefully near you. I've put furosemide in green because the values were as little as 4, but you can see they're all generic. And so it's not as though torsemide is significantly more expensive than furosemide. So I don't think that for many patients, cost is a major consideration. Though I will grant that a $5 difference for many patients is a very important difference. And this is for 30 tablets. This is a monthly prescription. Okay, so that's one argument. Let me talk a little bit about RAS. So this study randomized patients to torsemide and furosemide, and it looked at renin and aldo levels before and after. And in the torsemide arm, the renin and aldo levels were higher after the initiation of therapy, whereas in the furosemide arm, they were not. And what this suggests is aldosterone receptor blockade. And that's exactly what has been postulated to be occurring here. Right? So if you block the aldosterone receptor, the feedback is going to be an increase in renin and aldo. But you're blocking the receptor, so the actual negative effect of aldosterone is mitigated by torsemide. So that has been shown here. It's been shown in animal studies as well. And this, as I alluded to earlier, could be a potential mechanism by which there's less caluresis and less potassium wasting with the torsemide as compared to the furosemide. All right, so the last thing is that there may be some antifibrotic effects. And so I'll make a couple comments before I show you some data. And so the first is that I think we all know that there is a key role of myocardial accumulation of collagen fibers in worsening LV function in heart failure. And what's interesting is that aldosterone may play a role in this mechanism of myocardial fibrosis. And so the idea is if aldosterone plays a role, and this was new to me until I began reading up on this topic, but if aldosterone plays a role in myocardial fibrosis, you can imagine that a blocker might help to mitigate the fibrotic effects. And therefore, as something like torsemide might have antifibrotic effects. And that's been shown. So this study looked, again, randomized trial of torsemide versus furosemide, and it looked at a molecule, this PIP, which is associated with exaggerated myocardial deposition of collagen in the heart. And in the torsemide arm, after treatment, there was less of this molecule than furosemide. So, I grant you, very, very soft outcome, right? This is not like cardiac MRI, but it is at least consistent with this idea that torsemide may have antifibrotic effects that are unique to it because of its other effects that furosemide just does not have. So torsemide might affect RAS in a positive way. and might have antifibrotic effects. And so the way I look at it is it's kind of more than just a loop diuretic. And so, and it gets at some of the things that are problematic about the pathophysiology of heart failure. So if these end up being borne out from additional studies, it might be part of the reason why the data to this point suggests better outcomes with torsemide versus furosemide. All right, so I tried to argue that the evidence as we currently have it favors torsemide, that maybe some of this has relates to the fact that it's got better bioavailability, it lasts longer, but also that it's got these other non-loop diuretic effects. All right, so for this, I've also got 3 recommendations. I think if you have a patient who has new heart failure, I would say that there's really no good data, at least, to show why furosemide should be the leader. We are comfortable with it, but I'll be honest, we were comfortable with warfarin for decades. And I don't see people say, well, you know, warfarin's been around. I prefer this to keep with that as opposed to apixaban. I grant that the apixaban and DOAC data more generally is a lot stronger than the data I've shown you. But I don't think that familiarity should be a driving consideration for all of our clinical decisions. If you are considering changing a patient from one to the other, the conversion is, you'll see it most often written as 2 to 1. So 20 milligrams of furosemide equals 10 milligrams of torsemide. If you look at these studies where they randomize patients, the final drug dose often ends up being 4 to 1. And so meaning, you know, 40 milligrams of furosemide to 10 milligrams of torsemide. So I think it's between these two, between 0.5 and 1. And if you are the kind of person who was going to start someone on 20 BID of furosemide, I think it's reasonable to start someone on 10 a day of torsemide as a comparable dose. And obviously it can be increased. And I'll say we may get a more definitive answer when Transform HF comes out. This is a study that's going to include 6,000 patients. It's a randomized trial of furosemide versus torsemide. It also is unblinded, which I haven't seen a good explanation for why all these studies are unblinded, because it's not like we're giving IV versus PO. This won't be completed until August 2022, so we're not going to have results for over a year. And so maybe this isn't convincing, and you're going to stick with furosemide until you see the Transform HF results. And I wouldn't judge you for that, because I think the data I've shown you, though I think it's at least moderately convincing, it isn't so strong that, for example, the ACC/AHA has come out and said, you know, torsemide needs to be the drug of choice. I will say I'm not the only person saying this, right? There are people who have written, for example, editorials and other pieces suggesting that torsemide should be our drug of choice. All right, so have I convinced you on this one? Over here on the right, you're much more likely to use torsemide. Over here on the left, you're much less likely to use it. You love your furosemide, and nothing I can say will change you. Equally likely, and then down here is for the person who has always been a lover of torsemide. So I'm going to leave that up, David, while we take some questions.
Great, thanks. So we got a couple. First one, I need to say that you deserve an annual invitation every September to give Graham rounds. So that's the first one. That's a comment.
Well, I really need to have that adjudicated by the cardiology fellows. So they're going to have to unmute themselves to say whether or not they endorse that statement.
Well, I mean, a third of them won't be here in September. So
that's true. It's a whole new audience.
So you mentioned the cost difference, so that was one question. What about side effect profile comparison between the two?
Yeah, no, it's a good question. I'd be curious if maybe the person who has that question, if they want to either unmute themselves or put into the chat if there's something that they're thinking of. I didn't see data suggesting that the side effect profile is different, and if anything, fatigue is not a side effect, but some of the quality of life measures that we usually don't ascribe to, a loop diuretic seem to favor torsemide. So I'm unaware of anything, but I like to be shown the way. So if there's something that this person has in mind, I'd love to hear it.
Acute kidney injury.
Oh, okay. That's a great question. Let's imagine that the mechanism of action here is that torsemide is just a stronger diuretic, leads to more diuresis. And so that's why maybe some of these outcomes are better. Are we then seeing more of an increase in creatinine and more true AKI? I'm unaware of data from the trials that I reviewed showing that, but I can't say with certainty that isn't there, because I don't want to say something that may be inaccurate, but I don't recall coming across anything suggesting that AKI is more common.
Great. And the studies that you mentioned, were they in acute decompensated heart failure? Because they seem to be long-term outcomes.
Yeah, I should have made that clear. Thank you for that question. So unlike the first study or the first topic, I should say, where I concentrated exclusively on acute heart failure and said sodium restriction isn't warranted there. The studies I showed you for the second topic, for torsemide versus furosemide, were long-term studies. They often enrolled patients in hospital with acute heart failure, but most of these studies included patients who either had a heart failure reason for admission, but some of them did not. So if maybe you're saying to yourself, okay, some of this is convincing, but I just know how to dose IV furosemide. Like I'm just good at giving 40 of IV in someone who's presenting with acute heart failure, and when they were on 40 of PO at home. Nothing I've shown you really suggests that you have to change that practice. I would argue that because the bioavailability of torsemide is so good, that you can use oral torsemide in a patient with acute heart failure, with the caveat that if they have acute pulmonary edema, you still want to go with an IV diuretic because the onset of action is 5 minutes versus 60. So that's a lollygagging way of saying to the questioner, no, these studies were not really geared towards acute heart failure. I still try to encourage my teams to use torsemide in the setting of acute heart failure because the bioavailability is so good and it makes for a seamless transition. But I think our comfort level with, if you just really need to get the fluid off and you're just I don't want to learn on this patient with acute heart failure, I think starting with IV and then transitioning to oral torsemide is also quite reasonable, because we transition from IV to oral furosemide all the time. And so I think transitioning from IV furosemide to PO torsemide is not problematic, right? 2 to 1 is where you can usually start. Hopefully that answer is not too wishy-washy.
Okay. We had Joel Toff gave a grand rounds earlier this year. So
I'm nervous you're going to say he disagrees with everything I said. I gotta
the question is, what would he say? So in my interpretation, what WWJD, what would Joel do?
You're asking me that?
Yeah.
Gosh. I would say, and you can bank on this, he would agree 100% with everything I said. He would endorse it 100% because it is so overwhelmingly convincing. Actually, I don't know I haven't asked Joel this question, but I am curious about his feeling of some of these non-loop effects of torsemide. I don't know. I haven't asked him that question. It's a good one.
Yeah. Or any nephrologists who are on the call right now.
Yeah, if any nephrologists are on, have at me. I like to hear rebuttals, because the only way to make arguments stronger is to hear the most powerful rebuttal and think, okay, maybe I need to soften my stance, or maybe I need to have a counter argument to that rebuttal. So I do need to hear things. Hey, cardiology fellows, are you not going to chime in, guys? I've been waiting for you.
Hi, I'm one of the cardiology fellows. So in regards to salt intake and heart failure,
Yep.
it is a controversial subject, but I think the salt restriction is mainly in benefit of your hypertensive patients. And as we know, a majority of your heart failure patients are going to be African American with hypertensive heart disease and mainly with LV failure as well. So I think saying no salt restriction is doing those patients an injustice, especially when the studies that showed that salt restriction may have worse outcomes were lacking in your African American patients. So that's why we had a main issue with that statement, because it's not representative of the population, especially the population that's suffering from congestive heart failure.
Sure.
And, it has been shown benefit in hypertensive disease. So
Yeah,
we
I
are
think
for
that's
salt
why-
restriction, 4 grams at a maximum salt restriction. That is what we are endorsing, or
Yeah.
would like to.
And I like to hear what the experts have to think, right? And so I didn't say this up front, but I'm not a cardiologist, right? And you, the box of cardiologists have expertise that I do not have. I will say that again, the recommendation I have is more for acute heart failure, and I think sodium restricting during the acute heart failure setting is different than sodium restricting in the chronic setting in a patient who has hypertensive heart disease or hypertension without heart failure. You're 100% correct on that. And you're also 100% correct that the studies I showed you were basically exclusively from Brazil. So their generalizability, we have to take that into account. David, anything else?
Yeah,
Yeah.
so one last thing, sorry. In the setting of acute heart failure exacerbation, at least from what we could find, all of those studies didn't have a standardized treatment in the acute setting. So they accounted the differences in outcomes to that. So maybe it needs to be reproduced in a more reliable setting in order to see exactly like the outcome of acute sodium restriction. So in our thought is that it has such a benefit in controlling the factors that contribute to a heart failure exacerbation, and the bad outcomes are not readily reproducible and may not be significant to the population that we're treating. So we don't see, the statement that it should not be used is very strong, especially since the evidence is not really in support of that.
All right, thank you for that.
Question about spironolactone versus torsemide for heart failure.
Oh, so that, it's an interesting question. When I've talked about this with other people, I've gotten the question, okay, so let's say I want to become a torsemide advocate. Do I still need the spironolactone? And the answer I would say yes, right? If they have otherwise an indication for an aldosterone inhibition, whether or not spironolactone or eplerenone, I would argue that you should still use it. With the caveat, of course, in the back of our mind that patients who, in like for the RAL study, for example, that compared spironolactone to placebo, that study was done long enough ago that I suspect just about every patient was getting furosemide as their diuretic of choice. So that it's a reasonable question, but I don't think that the aldosterone antagonism is strong enough with torsemide that you can abandon usual goal-directed therapy.
Right. In the interest of time, Tony, that was fantastic. Wonderful. I just wanted to close with one question, which we've kind of already encountered. When you have, wonderful. How do you go about using your evidence-based beliefs to counteract historical, clinical, what we've always done clinically, like, oh, well, we always do this and it's always seemed to work. Why would how should I change this? So how do you buck the trends?
Yeah, so I'll try to make this brief because I know we're over time. You don't do it as an island, right? So again, for me to try to do some of these things alone is in some ways silly. So I'll give you an example. The treatment of hypertensive urgency. I think there's a move away from aggressive treatment of hypertensive urgency on the inpatient setting. But the reality is, if I do a session with the internal medicine residents, I'm like, hey, don't treat hypertensive urgency. And all of the nurses that they work with continue to see it as important to bring that blood pressure of 180 down. We're not going to get anywhere. So there needs to be more of a culture change. And I think the way to change your culture is within an institution, and sometimes starting small with a unit. I'm the unit director for one of our wards here at VA Boston. So I've done teaching sessions with the nurses on oxygen supplementation, hypertensive urgency, and you have to create a collective agreement around something. And you have to pull in allies like the cardiology fellows and go back to them and make the case to them again and say, I hear you guys, but let me try to make that case again. Because if you can't convince another group of experts, you're also not gonna make any ground. So don't be an island. It's got to be multidisciplinary, and reach out to the experts and see if they can poke holes in your argument, like cardiology fellows were trying to do today.
Thank you so much, Tony.
All right.
Grand rounds, very thought-provoking.
Yeah. So here's my email. I would love an email from any of you. My daughter Hayden on the right, she's staring at you, ordering sodium restriction and ordering furosemide. She's not judging, she's just staring. And my son is just happy. So thank you for having me.
Thank you, Tony.